we'll go ahead and get started here. I've probably met some of you, but my name is Larry Borgeson. I've been in the lab field for about 35 years now. I am retired Air Force. I've worked for a couple different companies, Vita, Serona, as technical demonstrators for their products, porcelains, teeth, dentures, so on and so forth. I've worked in large labs like 35, 40-man labs, all the way down to my own personal lab, which is one person. So I do have a lot of experience in all facets of the lab industry, not just to include removable. So when you guys have questions, you can ask me pretty much any of the questions you have. So we'll go ahead and get started there. A lot of this stuff is just, you already seen these forms. These have been around the school for a number of years now. I'm not going to go into great detail on them. They're all hanging up downstairs in the clinical lab when you're going to do model work. Just kind of follow the guidelines. One of the biggest things I see when models come up to me is on mandibular models, somebody has been teaching you guys to do horseshoes. When it comes to removable, make certain the tongue space is filled with stone, because if it's traditional and they flask and pack this, they put it under immense pressure, and a lot of times these models fracture during the flasking process. So when you're dealing with removable, always put the tongue space with stone instead of just leaving it in a horseshoe form. Again, I'm just going to skip through some of these. This is your Rpd form. The only thing that this is required for is metal RPDs, not really Valplast or acrylic partials, just metal. Again, custom trays, follow those guidelines downstairs, and I'm pretty certain these guidelines are going to change when Dr. Tucker takes over the removable program I think at the end of this semester, I believe. So, yep.
So, and that's an important point. So, Dr. Tucker will be taking this over. He's a prosthodontist, right? Basically, he might have different techniques, but you're going to end up in the same spot. And, there might be a different technique for border molding on a complete denture, but it's still doing the same thing. It's just a different material. You might not reline it as much. That was something that Dr. Durham did, and I was taught, so I carried that through, but maybe those go out the door. So try to not get too frustrated, because even though things are changing, you're still going to get this similar final product. It might just be in a different way, which I think is great, because then you're going to learn multiple ways to see what works best for you. Okay? Sorry.
No, you're fine. Dr. Homer's absolutely correct. There's about 100 different ways of doing something right, but there's always just one way of doing it wrong. So if you're dealing with your attendees or your GPLs, each person has been taught a different way within whatever dental school, whatever experiences they've had over the last 10, 15, 20, 30 years. So I'm not going to hit on these because of the fact that Dr. Tucker will probably change certain scenarios. There are things with wax rims that we're looking for as a lab. As a lab technician, I don't see lips and gums and faces and cheeks and any of that information. I see a piece of wax stuck to a base plate, and on those, the maxillary creates the aesthetic part of my setup. The mandibular creates the functional part of the setup. So I'm looking at the labial and buccal surfaces for my labial buccal corridor. So when I'm setting my anterior and posterior teeth, I'm using those references to be able to guide me when I'm setting those planes. My occlusal is going to be the occlusal plane that you set on your maxillary wax rim. So if you want your teeth in a certain horizon or zenith, I need to be able to mount that or digitize that so that my plane of occlusion matches your plane of your wax rim. Mandibular, there are some good things about it. Traditionally, all I'm doing once I have my maxillary completely done, completed setup with my Curva Speed and Curva Wilson, I'm just placing my mandibular teeth into an occlusion against my maxillary. Does it go into crossbite? That's all just dictated by the ridge and everything, but for the most part, I'm just setting my mandibular directly to my maxillary and creating the function when I go into my slides, protrusive or lateral movements. So wax rim, you want about 40 millimeters in height, 22 and 18, so that we're actually gauging what signs that said these are the averages. So those things won't change. Those, I believe, will be the same no matter who teaches that. So on that, I'll just move past this because you'll be able to read this or see it when Dr. Tucker comes through. Again, these bite records, these were made by Dr. Durham back in the day, and I'm certain these slides will change, so I'm not going to go through them a lot. With metal frameworks, this is an important point for metal partials. It is important for the lab to have a survey design model, because when we go to make the metal frameworks, we're actually taking our master cast and we're actually going to transcribe the tripod points so we can resurvey the master model. And there's about 5 different steps, and I've got some more of the lab things that I'll show you later on, but it's important to have a survey design model with the case so that the lab can actually transfer those survey marks and redesign the metal framework based on the path of insertion that you guys set. I'm not going to go into the functions. This can get confusing quickly, so I'll just pass that through. Now what we're talking about, this is where it's going to be interesting because you'll see how the lab is taking on the product of an RPD all the way through the set. So in a metal RPD, we pour master impression with our final model. Usually I like to use die stone, which is a type 4 hard stone. Then once that's done, I like to duplicate it. This is how I was trained, because on the virgin model, the original model, I don't want to touch that until the very end product is completed, so that I'm not destroying that model that's going to go all the way through the process of the RPD through acrylic. But we have to do that duplicate model and then survey, block out, do all the things we have to do to that model to be able to fabricate a metal framework on. That's where I was saying that survey models are very important, because that's where we're going to transfer the survey marks and actually dictate where our undercuts are. So when we're putting our I-bars, T-bars, acres class, where we can gauge the undercuts. Once that's done and we block that out and we survey it and design it, then we have to duplicate it in an investment material, which you'll see on the left screen over here and the right, just 2 different colored investments. Because that model is what you're going to wax the framework to before you cast, because that whole model gets invested into a ring. And that's how we go ahead and cast metal directly to that model, and it gets destroyed upon divesting. And you can see how somewhat in here the spruing techniques that they use, and of course the end sprued cast metal framework on the right. And then from there, all we're doing is metal finishing it, getting everything polished up, and then it goes on to your the original virgin master model at the very end of the process. Again, I've talked to you a little bit about the wax rims and the setup. There's multiple different ways of doing the setup. There's no right way of doing it. We do have to incorporate a guide plane. We have to incorporate the occlusal and the labial and buccal aspects and the curve of Spee and Wilson through the setup. But I'm not going to go too much into detail on that. If you later on in your studies, if anybody's deciding to go into pros or anything like that, I've worked with a couple different pros students that have decided to apply for prosthetics. I will go really hard into a lot of this stuff one-on-one with each student that decides to go more into the advanced prosthetic type of courses. So, but for right now, I'm not going to hit it too much. These are all try-ins. Wax rims, again, I just talked a little bit about the wax rims, and there's only one way to do the wax rim, and that's over the ridge. The heights are important because we have to make certain we have 40 millimeters, 22 and 18, but the markings, this is where it sometimes gets confusing, because the markings on the actual wax rim, sometimes I get a midline, sometimes I don't get a midline, sometimes I get a high lip line or canine lines. It's important to have all 3 aspects, because the occlusal plane of the wax rim is dictating where my incisal edge and my cusps of my molars and my posterior teeth are going. but I also need to know where the midline is. I also need to know the high lip line because of the fact I need to know how long the tooth is, and I need to know the cuspid lines because I need to know how wide from cuspid to cuspid those are. So those three markings are very important on the wax rim for a technician. Sorry, this thing fell off. It's very important from the lab aspect because we don't see the patient. So if we don't have the right markings or they're marked in the incorrect positions, you're going to get the tooth set up in the incorrect marking areas. So if you don't give us all the detail, we're just kind of guessing at where the teeth are gonna go. So those markings are very, very important. Again, this is more for setting up, and I'm not gonna go too much into that. Fabrication steps. Everybody knows that you have custom trays for your very first appointment. Then it goes to wax rims, then it goes to setup, then it goes to finish. If all goes well, you're talking 5 appointments from your very first preliminary checkup. If things don't go well, it could be 2 or 3 try-ins because the bite is off, or we have to reset it for whatever reason. Patient didn't like the color of the teeth, whatever the scenario might be. But each subsequent step requires another appointment. So it's ideal to get everything correct at the very beginning so that we're not pushing the treatment of the patient further and further back. Now, we're also doing a lot more with digital dentistry when it comes to digital dentures. I don't have anything on the slides for that, but when it comes to full fulls or a full denture, we're actually scanning the models, we're scanning the bites, and we're actually setting up the denture using digital technology now and going all the way through printing of these dentures. This system's a little bit easier in some ways because we can actually go straight from the traditional wax rim and bite, and we can actually scan, design, print the models and go all the way through the base and the teeth, and if everything goes well for the try-in, the patient's done at that 3rd appointment. If it doesn't go well, you just have to retake a blue moose or a bite registration bite to recreate a brand new bite, and then all we do is reset the teeth directly to that new bite, and they're done on the 4th appointment. So it can save a few steps, but it's a little bit different in the way we go about it. As of right now, we're not doing any scans intraorally to get to that stage. We're still using the traditional custom trays, wax rims, and then we digitize from that. We're not actually scanning intraoral to get to the final step, not yet. The setup, this is traditional processing where we actually have to take the wax up denture and actually boil out. So we have to take the denture and the model, put it into a stone base and let it set, and we have to boil out in water. I'm simplifying it, but this is in essence what we do. Once it's boiled out, we put a alcoat or a separator on the model. All we're doing at that point in time is actually mixing up our acrylic and placing the acrylic directly into the mold. And under high pressure, we're actually compressing that material into that mold itself to fill the void where the wax was going. And that's where I was saying, if you don't have if it's a horseshoe model, sometimes those horseshoe models twist while inside that flask under that high pressure, and that's where they fracture, and that's where you can get bad fits of the denture and everything else. That's why it's important to have the tongue space filled. Relines. The relines here, part of the immediate denture coating, the D codes, is they actually get, and Dr. Homer might be able to be a little bit more specific, but I believe it is the full denture setup series, setups, try-ins, so on and so forth, all the way to the complete of the processing. Then they get 2, I believe, follow-ups for like chairside relines, and then 6 months later, when the healing phase goes, which is determined by you and your attendees, then they get a final lab reline as part of the entire process. So this denture reline is the lab way of doing it. I've seen this a couple times where the students have actually taken the reline and they've just taken the denture and used it as a custom tray. They just held it into place, and then they wonder why it doesn't fit at the end the important part is when you go to take a reline impression, that you're using the original denture, you're using a wash or the or the impression material inside the denture, but they have to bite into centric occlusion to be able to get the correct vertical. Because if you're just trying to hold it in like a custom tray, you're not holding it in the correct position. So they have to place it and then bite into centric, then let the material cure, then it comes out of the mouth, and that's how we can place it into what we call a reline jig. That's creating centric occlusion for us in the lab, which if done correctly, it's gonna go back to you guys, try it in, everything should fit perfect. And the patient's walking out the door with a reline denture that will fit better than when it was originally made.
Do we border mold at that reline as well?
The border molding, it depends on how well the original impression was taken in the first place. What I find when it comes to immediate dentures, there's not much flange. They don't always capture the most posterior area behind the hamular notch or the retromolar pads. So yeah, border molding sometimes is required at this point, because whatever you do in the chair is going to be an exact replica inside the original or the final cured acrylic from the lab. So if you have to extend the flanging or have to extend the distal extensions of the dent, either max or man, that acrylic will be the final acrylic at the final stage. So yes, you may or may not have to, based on how well the original impression was. The bottom right is just what we call our reline jig. That's how we can keep everything in centric occlusion, is because once we pour the model, we then take the model, the denture, place everything into this 3-part jig. We let everything cure, then we pull it apart, and then we can actually place the denture, the working model, and the centric, basically the occlusion, all back together when we go to actually pack the acrylic.
So let's say that you have to slightly adjust BDO
Yep.
on a reline.
Uh-huh.
What's your way of going about that to make sure that you're have that established? Meaning, how far does the patient bite into centric to make sure you're BDO? Does that make sense?
Yeah, what you're saying is if you have to reestablish a BDO,
Yeah.
say, and this is a good question because it happens quite often where under an immediate denture, if the bite wasn't correct in the first place, and now you're trying to correct it at the reline stage, the best way you do that is you can do a couple different methods. You can mark dots on the chin and the nose, measure those areas, so when they're biting down into what you consider the correct vertical, you can actually, once they start to bite down against their opposing dentition, then you can actually mark and have them bite down to the specific dots measurements. That's one way of doing it. Another one is sometimes the left doesn't match the right. So one's closed exactly the way you want, the other side's a little open. What you need to do at that point in time is take the maxillary denture, and you take that as almost a custom tray impression, like I told you not to do. In this scenario, you want to do it that way because then you can line it up correctly so you can get the midline correct and everything else. Then you hold it for curing. Once it's established the way you want, leave it in the mouth because it's the best suction you're gonna get. If you try to break the suction and pull it out, trying to get it back with the same suction, it might not seat correctly. Once that's set, then you go to the lower. Now you take the same weight. Now you just have them bite into centric and making certain that everything closes correctly. And now they're biting into that same position. So the void might be thick on one side, thinner on the other. But when we go to reline these, the new acrylic will fill those voids correctly. And when you get it back, it will fit exactly like you took it in the mouth. Does that help answer it?
Yeah.
So you can make, again, you can make slight adjustments that way. You don't want to make massive adjustments. But what I find is doing the max first because that's where the aesthetics, that's where patients freak out. If the aesthetics aren't right, that's where that goes haywire. But that's why I do max first, then mandibular. But slight changes can be done that way. Again, this is just showing you the same process. There's different ways of doing it. We have magic box, we've got reline jigs, there's multiple different ways of doing it, but they always have to go back into eccentric. This is just showing you a couple other ways of completing the same reline. And this is just showing you the process. Once we get everything relined up, we have to grind and roughen the actual intaglio of the denture so that we get good bond between the new acrylic and the old. So that's us just basically pouring the acrylic into the denture before we actually put it back in the reline jig. Then from there we have to actually cure it under time and temperature and pressure, and we do that in a heated pressure pot. And then once it's done, then we just go out and finish the denture, polish it up and get everything done. Yep.
Do you do a soft reline and then hard, like, is that enough info for you to then hard reline it? Does that make sense? Like,
Yeah, they are.
yes?
Yeah, if they already have a soft reline, you just want to make it hard. Is that what you're talking about?
Yeah.
If the fit is fantastic, this is what you're gonna have to determine on the chair. If that soft reline is exactly happy, everything's perfect, that's all I need, because then I can just pour stone directly into the intaglio of that denture, like a model. And then what I do is I have to grind all that soft reline material out of there to create the void, and I have to go all the way down to the hard acrylic, because you can't put acrylic directly to a soft reline material. It won't bond, and it will just bust out of there. So you have to remove all that soft reline material, but if you're doing that technique, the lab will do it. If you're using and saying, oh, I still don't like the fit, you can't actually put the impression material thin wash directly onto the actual soft reline material, and then take the impression that way too, if you're wanting a little bit more detail, and then we just grind everything out after we reline jig it.
I guess in my mind, it's a way to let them try it, is kind of what I was wondering, you know, let them try the soft reline and make sure they're happy with it, right?
Yeah, I mean, absolutely, you can do it that way. A lot of times the patients really like the soft reline because it's a little bit more comfortable, it's more like a pillow. But they delaminate from the hard acrylic over time, then you're trying to get that stuff out of there and keep doing it, you'll hate life. Repairs, denture repairs themselves, there's different complexities of denture repairs. I'm gonna hit on one point, I want everybody to know this. Tell the patients never to super glue their repair, ever. They like to take denture teeth, super glue them back into the denture, they try to super glue dentures back together, and it never works. I can't get them back together, but if it's just a clean break, most of the time it breaks perfectly clean. All they have to do is bring it back in, and if the two hemispheres go back together, we super glue it, seal it back together, then I can pour them all directly into that. Same thing with adding the tooth back. It's when they start super gluing it where things become a nightmare, because you'll have to re-break the denture, basically trim all that super glue off, and then you have to take a pickup impression, which is taking both material, both hemispheres of the fracture, placing it back in the mouth, and then actually taking an algin impression in there. Then we have to pour it up and then repair the denture that way. So if you're ever delivering a denture, a partial, anything, just tell them if it breaks or a tooth breaks out, which will happen. I mean, they're pieces of plastic and they're not real teeth and real bone, and it will break at some point in time. Hopefully they'll keep it for years and years and years without fracturing, but if they do, tell them just not to try to super glue it, bring it right back in, and it makes life a lot easier to repair for both the dentists and the lab. And there's multiple different ways of repairing, so I'm not going to go into it. These ones, you can see the triple fractures. These ones, a lot of times, you always have to get, if it's here at the school, just bring it up to me or Diana, our new technician, and we'll evaluate the fracture and see where we need to go with it. Usually with triple fractures, if we can get all three components back together, it's simple as that. You just drop it off the lap slip and we fix it and it comes back to you guys. If all three of those don't go back together, that's where we can say we can quickly repair one of the fractures, then we'll have to send the other down to get a pickup impression, because we need to make certain it goes back together so it fits well. But usually you don't see this. The only time you see multi-fractures is if the patient steps on it or drives over in the car, or something bad happens. Usually you don't get them into threes. So, but if you do get a multi, just bring it up to us and let us evaluate it. Acrylic partials, that's exactly what it is. Everybody gets confused with acrylic partial, flipper. The best way to think of a flipper is usually it's 1 or 2 teeth. Flippers do not contain any clasping, and it requires just suction to hold it in. Hence the word flipper. When it goes in, it just kind of flips around. It doesn't hold real well. I personally don't do flippers here. I do interim partial or acrylic partials where I always put clasping where I can for retention purposes. But that's the idea of what a flipper to an acrylic partial to an interim partial denture is. All of these things are primarily short-term devices, something that they're just holding on to until a more definitive care product is being completed, either full denture, metal framework, so on and so forth. There is another option between acrylic partials, metal framework, and a complete denture, and that's a Valplast. It's a nylon-based denture. There's goods with them and there's bads with them. The goods are, they hold retention a lot better because they can bend a little bit to get them placed into the mouth. The clasping is more made out of nylon, so they don't break as easy as, say, a stainless steel clasp. But if anything happens with them, i.e. a patient loses a tooth, they're not repairable. You can't repair them, you can't add teeth to them. You can, but the caveat is they're not supposed to be, but you can repair them if need be, but ideally you don't want to. So that's the problem with the Valplast, plus they're very expensive to make. So when you get into that, just be aware of it. That's a flexible partial. You can kind of bend it around. I've seen everything from 1, 2 teeth all the way to a patient wanted a full denture in Valplast. Why, I don't know, but I've seen it done. But they're usually partial dentures for Valplast. That's pretty much the removable side of it. I just hit through a lot of that really quickly.